Hello doctors, this is Dr. Hira Salman. So let's continue our fourth session of hematology from this non-Hodgkin lymphoma. So see, non-Hodgkin lymphoma is a proliferation of lymphocytes in the lymph nodes and spleen. So we are going to see proliferation of lymphocytes not only in spleen but also in lymph nodes. Non-Hodgkin lymphoma is most often widespread at presentation and can affect any lymph node or organ that has lymphoid tissue. So it's widespread at presentation. It can affect any lymph node or organ that has lymphoid tissue. So any organ which has lymphoid tissue, we can see that non-Hodgkin lymphoma can be there. Non-Hodgkin lymphoma and the CLL are extremely similar, but non-Hodgkin lymphoma is a solid mass and CLL is liquid or circulating. So this is the main difference between CLL and HLL, that in NHL this is a solid mass. This non-Hodgkin lymphoma is a solid mass while the CLL is liquid or circulating. Now, what is the presentation and what is the most likely diagnosis? Say for example, your patient is going to present with painless lymphadenopathy. They may involve pelvic retroperitoneal or mesenteric structures. May involve. So it's not hard and fast rule that you are going to see involvement of retroperitoneal structures or mesenteric structures or pelvic structures, but we may find. Similarly, there is painless lymphadenopathy. The word painless is very important to remember here. It's not painful. It's painless lymphadenopathy. Nodes not warm, red or tender. We are not going to see warm or red or tender lymph nodes. B symptoms. Whenever it's written B symptoms, we have to think of three things: a triad of fever, weight loss and drenching night sweats. So if the patient is presenting with fever, weight loss and drenching night sweats, we are saying this, that this patient is having B symptoms. So suspect if the patient is having painless lymphadenopathy, he is having some involvement of mesenteric structures, retroperitoneal, pelvic involvement, and nodes are enlarged there, but they are not warm, they are not red, or they are not tender. But the patient is presenting with B symptom. He is having fever, history of weight loss is there, and history of drenching night sweats are there. So you can think of this non-Hodgkin lymphoma. Infection, not non-Hodgkin lymphoma, gives note that are warm, red and tender. Definitely in this in non-Hodgkin lymphomas we are not going to see this tender redness or warm. That is the symptoms of infection mainly. Now for the diagnostic testing, the best initial test is an excisional biopsy. That is very most important to remember. Best initial test is excisional biopsy. The CBC is normal in most cases. We are not going to get any clue from the CBC. High LDH levels correlate with worse severity. So if there is high LDH level, definitely we are going to see the worse severity. Staging determines the intensity of therapy. Staging non-Hodgkin lymphoma does not often change treatment because in most cases disease is widespread. Most of the time patients who are presented, they are mostly involving the stage 3 and stage 4. Typical staging procedures are, you can go for the CT scan of the chest, abdomen and pelvis, and we can also go for the bone marrow biopsy. That these two procedures are for typical staging procedures, but initially we will always go for excisional biopsy. Now for tip for us here is, the most common wrong answer is to do a needle aspiration of the lymph node. We'll never go for this, and we mostly go wrong with this thing, that we are not going to perform needle aspiration of the lymph node. We'll always go for excisional biopsy. Aspiration is not enough because the individual lymphocytes appear normal. So on an aspiration you're not going to get anything. Now for the staging point of view, stage 1 means that one lymph node group involved. Stage 2 means that 2 or more lymph node groups on the same side of the diaphragm. So on the same side of the diaphragm, if 2 or more lymph nodes groups are involved, then we are going to say this is stage 2. If both sides of the diaphragm are involved, we can say this is stage 3. And if it's a widespread disease, means anywhere in the body, you can say it's stage 4. So there are 4 stages of non-Hodgkin lymphoma: 1, 2, 3, 4 based on lymph node group 1. Stage 1, 2 or more but on the same side, 2. On both sides, 3. Widespread all over the body, 4. Now how are you going to treat your patient? If it's a local disease, say for example if it's stage 1A and 2A, so definitely you will go for the local radiation and small dose course of chemotherapy. So if it's stage 1A or 2A, we can only go for the local radiation. We can go for the small dose and course of chemotherapy. But if it's an advanced disease, say for example it's a stage 3 or stage 4, or the patient is having B symptoms: fever, night sweats, drenching night sweats and they are the triad in case of B symptoms, right? What was the triad? The triad of fever, weight loss, and drenching night sweat. So if the patient is presenting with these B symptoms, then we can say we can go for a combination of chemotherapy with CHOP and rituximab and antibody against CD20. So these are the treatment protocol for advanced disease. For advanced disease, those who are having stage 3 and 4 plus B symptoms, weight loss, fever, and drenching night sweats. So we'll go for the combination chemotherapy with CHOP. CHOP stands for, it's an acronym. C stands for cyclophosphamide, H stands for adriamycin, doxorubicin, hydroxy, daunorubicin. O is vincristine, that is Oncovin, and P is prednisone. So this CHOP, we can go for this CHOP and rituximab, which is DMARD, and antibody against CD20. This is for advanced disease. But for the local disease, we'll only go for the local radiation or small dose of chemotherapy. This CHOP, we need to remember cyclophosphamide, H for hydroxy, daunorubicin, that is adriamycin, O is vincristine, that is Oncovin, and P is prednisone. So here, this point to ponder, this box is non-Hodgkin lymphoma presents in advanced stages in 80 to 90% of cases. Most of the time they are not presenting as a local disease. 80 to 90% cases they are going to present as an advanced disease. Now we are coming towards mucosal associated lymphoid tissue. This is lymphoma of the stomach in association with H. pylori. So if you are going to see lymphoma of the stomach, which is mostly associated with H. pylori, think of this mucosal associated lymphoid tissue, and we are going to treat the helicobacter with clarithromycin and amoxicillin. This is the best option for the treatment of this helicobacter. First is clarithromycin in combination with amoxicillin, and this is lymphoma of stomach in association with helicobacter. So this mucosal associated lymphoid tissue. Now we're coming towards Hodgkin disease. Definition, presentation, diagnostic tests, B symptoms, and staging of Hodgkin disease are just same as like non-Hodgkin disease. But Hodgkin disease has one very strong feature related to pathology, and that is has Reed-Sternberg cells on pathology. These Reed-Sternberg cells you're not going to see in non-Hodgkin lymphoma. They are peculiarly for Hodgkin's disease. Now how we are going to differentiate between if it's a Hodgkin lymphoma disease or non-Hodgkin lymphoma. So in case of Hodgkin disease, that is mostly local, and most of the time it's stage 1 and stage 2 in about 80 to 90% of cases. But if it's a case of non-Hodgkin lymphoma, you are going to see severe disease, advanced disease involving stage 3 and stage 4 in about 80 to 90% of cases. Hodgkin disease, local, so definitely it centers around cervical area. Most of the time centers around cervical area, but non-Hodgkin lymphoma is disseminated. You are going to see widespread. Reed-Sternberg cells on pathology, they are very peculiar for Hodgkin disease, and definitely in non-Hodgkin lymphoma you are not going to see any Reed-Sternberg cells. So no Reed-Sternberg cells. In case of Hodgkin disease, we have some pathology classification. Say for example, lymphocyte predominant has the best prognosis. If the lymphocytes are prominent here, that lymphoma, that disease definitely has got best prognosis. But lymphocyte depleted has the worst prognosis. If lymphocytes are not there and it's depleted, that Hodgkin disease is actually having a worse prognosis. But if lymphocytes are predominant, that is usually have a good prognosis, a best prognosis. For the pathology classification of non-Hodgkin lymphoma, we have Burkitt and immunoblastic have the worst prognosis. So only two categories, that is Burkitt and immunoblastic. These are the two non-Hodgkin lymphomas. They have the worst prognosis. Now for the treatment option. Stage 1A and 2A. If it's stage 1A and 2A, definitely you're going to go for the local radiation with a small course of chemotherapy. Definitely you're going to give this chemotherapy, but very small course, and locally you're going to radiate it. If it's lymphoma, it's stage 1A and 2A. But if it's stage 3 and 4, or anyone with the B symptom means that night sweats, fever, and weight loss, then you're going to give this ABVD. So for the stage 3 and 4, you have ABVD. ABVD again is an acronym for A for adriamycin, doxorubicin, B for bleomycin, V for vinblastine, and D for dacarbazine. So these are chemotherapeutic options, especially for those who are having stage 3 and 4 or anyone with B symptoms. Now, relapses after radiation therapy are treated with chemotherapy. Say for example, if the patient comes to you again with a relapse After radiation therapy, then you are going to treat your patient with chemotherapy. If the patient relapses after chemotherapy, then you are going to treat your patient with extra high dose chemotherapy, or you may go for bone marrow transplantation. So if the patient is coming back after radiation therapy, you can always put your patient again on chemotherapy. But if the patient is relapsing after chemotherapy, then definitely you are going to put your patient on extra high dose of chemotherapy, or sometime you can opt for bone marrow transplantation as well. Now we're coming towards complications of radiation and chemotherapy. So definitely all things has their complications. So radiation and chemotherapy increases the risk of solid tumors, especially radiation. They can increase the risk of solid tumors such as breast cancer, thyroid or lung cancer. A screening for breast cancer is recommended 8 years or more after treatment. So if you are treating a patient with radiations or chemotherapy, so it's necessary to screen your patient, especially female patient, for breast cancer, which is actually recommended also 8 years or more after treatment. Radiation also increases the chances of premature coronary artery disease. So that is again a problem, that with this radiation there is a chance of getting premature coronary artery disease. The risk of acute leukemia, blood cancer, myelodysplastic syndrome and non-Hodgkin lymphoma as a complication of chemotherapy is about 1% per year, but still it's there. So we have some complications like acute leukemia, MDS and non-Hodgkin lymphoma, and these are the complications of radiation and chemotherapy, but the risk is very low. It's about 1% per year. Now, which of the following is most useful to determine dosing of chemotherapy in Hodgkin's disease? So by which category you are going to, which of the following is the most useful to determine dosing? How you are going to determine dosing? What is the most useful chemotherapy in Hodgkin's disease? So that is MOGA, that is nuclear ventilogram. Why? Because adriamycin or doxorubicin is cardiotoxic. So this is definitely, see, the nuclear ventilogram is the most accurate method of assessing left ventricular ejection fraction. So we can go for this detection of this ejection fraction, and that can only be done with the help of nuclear ventilogram. Use the MOGA scan to determine whether cardiac toxicity has occurred prior to the development of some symptoms. Why they are more emphasizing on adriamycin? Because adriamycin, doxorubicin is one of the chemotherapeutic agent which is very cardiotoxic. So how we come to know that this cardiotoxicity is because of adriamycin, or this cardiac toxicity because of any previous pathology related to cardiac muscles? So for that we actually opting for this nuclear ventilogram, that is MOGA scanning, because if you are going for the MOGA scan, it's actually determine whether cardiac toxicity has occurred prior to the development of symptoms, or you can't use adriamycin if the ejection fraction is less than 50%. So definitely this is also very important, because we can't use adriamycin in those patients who are having ejection fraction below 55%. Why? Because adriamycin again is a cardiotoxic. So how you are going to use this medication in your patient who is already having ejection fraction less than 50%? So don't use that. Radiation alone is never right for lymphoma. So we'll definitely not go for this radiation alone. We have to give chemotherapy as well. Now we're coming towards adverse effects of chemotherapy. So these are very important adverse effects. We must know about them. First of all, chemotherapeutic agent like doxorubicin. Doxorubicin mostly associated with cardiomyopathy. You should be very particular about cardiac patient if you're giving this doxorubicin. Vincristine usually cause neuropathy. Bleomycin for the lung fibrosis. They usually cause lung fibrosis. Cyclophosphamide can cause hemorrhagic cystitis, and cisplatin can cause renal toxicity, ototoxicity and neurotoxicity. Why we are emphasizing on adverse effects? Because on the basis of adverse effect, you are going to decide whether you are going to use this chemotherapeutic agent in your patient or not. Say for example, if your patient is already a heart patient, you will never go for the doxorubicin. If your patient is having any lung pathology, definitely you will never choose this bleomycin. Or similarly, hemorrhagic cystitis, or if the renal are compromised, so you are not going to use cisplatin. So that is very important. Adverse effects are very important because you need to know where you are going to use these medications. Now we are coming towards multiple myeloma. Multiple myeloma is an abnormal proliferation of plasma cells. These are plasma cells actually which are going to convert into megaloblast, and they are soon going to convert in B lymphocytes. Actually, this plasma cells, they are actually responsible for the formation of antibodies. So myeloma is an abnormal proliferation of plasma cells, and these plasma cells are unregulated in the production of useless immunoglobulin, that is usually IgG or IgA, and IgM is a separate disease called Waldenstrom macroglobulinemia. That we should know that definitely if there is a normal proliferation of plasma cells, we are going to see some abnormalities related to the production of immunoglobulins, because these immunoglobulins are antibodies, right, and these plasma cells are responsible for the formation of antibodies. So they are specifically mentioned that if it's a case of IgM, if immunoglobulin M is a separate disease, if there is any pathology related to immunoglobulin M, we can say that disease as Waldenstrom macroglobulinemia. Why? Because this is specifically for IgM. These immunoglobulins do not fight infection but clog up the kidney. So that is important. If there is any something related to this immunoglobulin, this antibodies, definitely we are going to see they are not going to fight against infection, and instead of that they are going to clog up the kidney. Now, what is the most likely diagnosis? The most common presentation of myeloma is bone pain from pathologic fractures. So we are going to see pathologic fractures in a patient, and because of these fractures, patients are experiencing bone pain. A pathologic fracture means that the bone breaks under what would be considered normal use, and this is from osteoclast activating factor. Osteoclast, they are responsible for the bone resorption, for the bone lysis, which attacks the bone, causing lytic lesions, because they are actually going to lyse the bone. They are going to do the lysis of the bone so that calcium can release from the bone and come into plasma. So this osteoclast activating factor is also the reason for hypercalcemia. Definitely, if this osteoclast activating factor is activated, it's going to activate the osteoclast, and osteoclast will do what? They will do the lysis of the bone, and they are going to release calcium from the bones into the blood. So you are going to see elevated levels of calcium in the blood. So that is hypercalcemia. Infection is common because the abnormal plasma cells do not make immunoglobulins that are effective against infections. Again, this is important. Why we are going to see infection here? Because here there is a production of plasma cells. These plasma cells, they are actually not producing, but they are abnormal. They do not function properly, and they are not converting into immunoglobulins. That's why we are going to see infectious cases here. Now, how your patient is going to present? First of all, with hyperuricemia. This must be a presentation. Why this hyperuricemia? Because of the increased turnover of the nuclear material of plasma cells. Plasma cells, their turnover is high, so that's why definitely because of the nuclear material, when it's broken down, you are going to see hyperuricemia. In a case of anemia, how the patient is going to present with anemia? From infiltration of the marrow with massive number of plasma cells. So you are going to see infiltration of the marrow with massive number of plasma cells. So plasma cells, they are actually going to infiltrate, and we are so because of this infiltration of the marrow with massive number of these plasma cells, we are going to see anemia. And how we are going to see renal failure here? Why? Because from accumulation of immunoglobulins and Benz-Jones protein in the kidney. So immunoglobulins are accumulated, they are clogged up in the kidneys, and Benz-Jones protein you are going to see in the kidney. Hypercalcemia, more and more amount of calcium in the blood, and hyperuricemia because of the increased turnover of cells also damage the kidney. So this hyperuricemia, hypercalcemia, these two factors, they can also damage the kidney. Similarly, Benz-Jones protein, they are accumulating, they can cause accumulation of immunoglobulins, they can also cause renal failure. So renal failure and infection are the most common causes of death in myeloma. So most of the time, patient usually die because of this in case of myeloma. Why? Because of infection or because of renal failure. So how we are going to diagnose our patient? The first test done is usually an X-ray of the affected bone that will show lytic or punched out lesions. So this word punched out is very specific for multiple myeloma patients. So when you go for the X-ray, which is usually first test done, so you are going to see lytic lesion, that is known as punched out lesions. Free light chain ratio, that is FLC, free light chain ratio correspond with myeloma. So free light chain ratio corresponds with myeloma. Usually it corresponds to myeloma, with myeloma especially. Here you are going to see myeloma. This MRI showing bone and infarct. We are going to see the infarction here and on the left, and lytic lesions in the skull in the right. So you see these are lytic lesions here. Bone lesions in myeloma are exclusively lytic. Nuclear bone scan will show nothing because there is no blastic activity. The bone can pick up the nuclear isotope only when there is blastic activity. When there is blastic activity, only at that time nuclear isotope can pick up, right? But in the case of here, bone lesions in myeloma are exclusively lytic, but there is no blastic activity. So definitely if there is no blastic activity, you are not going to see anything on nuclear bone scan. Now, serum protein electrophoresis, that is also known as SPAP, shows an IgG that is 60% or IgA that is 25% spike of a single type or clone. If you're going for the electrophoresis, you will see immunoglobulin G more like 60% or IgA 25% spike of a single type or clone. This one clone is called a monoclonal or M spike. So if you're going to see any one clone or monoclonal thing, like one single spike of any immunoglobulin, that you can say that's an M spike. 15% have light chains of Benz-Jones protein only. So 15% cases we are going to see only light chains, or we can say that as Benz-Jones protein only. Additional laboratory abnormalities include, so what else we can go for? This point to ponder, we'll do it later. Additional laboratory abnormalities include hypercalcemia. Definitely you are going to see increased level of calcium in blood. You are going to see Benz-Jones protein, especially when you are going for urine immunoelectrophoresis. So at that particular time, you can see this light chains, that is Benz-Jones protein here, and smear with Rayleigh formation. Rayleigh formation means aggregation of RBCs upon one another. So we are going to detect the smear with Rayleigh formation. We are going to see elevated blood urea nitrogen and creatinine. It means that kidneys are not compromised. And bone marrow biopsy, greater than 10% plasma cells define myeloma. So when we go for the bone marrow biopsy, we're definitely going to see greater than 10% plasma cells, which actually defines myeloma. So it's a case of myeloma there. So most of the time, patient of multiple myeloma, they are presenting with hypercalcemia, they are presenting with Benz-Jones protein, they are presenting with beta 2 microglobulin levels. If they are presenting with smear, when you check the smear with Rayleigh formation, or especially these aggregation of RBCs, you are going to see on smear. Elevated blood urea nitrogen, creatinine you are going to see, and bone marrow biopsy, when you go for it, you will see mostly 10% plasma cells, which actually define its term, that is myeloma. Myeloma means plasma cells. Now, elevated total protein with normal albumin. So that's another feature. We are going to see elevated total proteins, but here normal albumin. Now, point to ponder, we just give one point to ponder above also, we need to cover it. Myeloma has a decreased anion gap. IgG is cationic. So if we go for the myeloma for the anion gap testing, so we'll see the anion gap is decreased in case of myeloma. Why? Because IgG is cationic. Cations means positive ions, and increased cationic substance will increase the chloride and bicarb level. So if cations are increased, they are going to increase chloride and bicarb level, and this decrease the anion gap. So definitely anion gap will be decreased. How? The simple thing is that if there are more cationic substance, they are going to increase chloride and bicarb. As a result, you are going to see decrease in negative gap, that is anion gap. Anion is negative and cation is positive. So IgG is cationic, and because of that increased cationic substance, it will increase the chloride and bicarb level, and that actually decreases the anion gap, that is negative gap. Alright, now again this point to ponder here. Rayleigh form when the IgG paraprotein sticks to the red blood cells, causing them to adhere to each other in a stack or roll. So this is just a pathophysiology, that Rayleigh form when the IgG preparation sticks to the red blood cells. IgG paraprotein when sticks to the red blood cell, then it's formed this aggregation, and that is known as Rayleigh formation, causing them to adhere to each other. So all of them will be will attach to each other in a form of stack or roll, and that is known as Rayleigh formation. For the plasma cells more than 60% in marrow, or FLC ratio is more than 100. So if FLC ratio is more than 100, and if you're going to see more plasma cells, that is about more than 60% in marrow, so definitely you should go for the treatment option. That is very important. So plasma cells should not be going more than 60%, and FLC ratio, if it's more than 100, we should always start treatment. You can see here, this is plasma cell in myeloma, especially these plasma cells in myeloma, and the Lucencio light area near the nucleus is the HOF, which is the Golgi apparatus. So you can see here, this is actually the portion, the Lucencio, the light area. There is light area, and that is known as HOF, which is the Golgi apparatus. Now, what is the explanation of the difference between urinary level of protein on urinalysis and the 24-hour urine? So what is the explanation for the difference between the urinary level of protein or urinalysis and the 24-hour urine? So here it's false positive 24-hour urine is common in myeloma, calcium in urine creates a false negative urinalysis, uric acid creates a false positive 24-hour urine, or Benz-Jones protein is not detected by dipstick, or IgG in urine inactivates the urine dipstick. So correct answer is Benz-Jones protein is not detected by dipstick. Why? Because Benz-Jones protein is detected by urine immunoelectrophoresis. It's not going to be detected by dipstick. We need to choose what is the explanation for the difference between the urinary level of protein on urinalysis and 24-hour urine. Alright. So for the urinalysis and for the 24-hour urine, we should know that Benz-Jones protein is not detected by dipstick. Definitely it's not going to be detected by dipstick. It's definitely going to be detected via immunoelectrophoresis. The urine dipstick will detect only albumin. If you are considering only dipstick, it means that we are more focusing on albumin. Now, what is the single most accurate test for myeloma? So, if you want to go for the single most accurate testing for myeloma, you will definitely go for bone marrow biopsy. So, bone marrow biopsy is the one by which you can go for the single most accurate testing for myeloma patient. So nothing beside myeloma is associated with greater than 10% plasma cells on bone marrow biopsy. Definitely you will go for, when you go for the biopsy, you will see 10% plasma cells, especially in the case of myeloma patient. The most common wrong answer is SPAB. We'll never go for the electrophoresis of those with an M spike of immunoglobulin. 99% do not have myeloma. So if the patient is having M spike and you are thinking of this SPAB, please don't think this. Why? Because in 99% of cases, SPAB will become negative and patient don't have myeloma. Most IgG spikes are from monoclonal gammopathy of unknown significance that does not progress or need treatment. So most IgG spikes are from monoclonal gammopathy of unknown significance. So that is a particular disease by which we are going to see spikes of IgG. Skull X-ray shows lytic lesion, but this is not as specific as massive plasma cell levels in the marrow. So definitely we will go for the skull X-ray. That will definitely going to show lytic lesion. But here it's not the single most accurate test. Here the single most accurate test is urine here the single most accurate test for myeloma is bone marrow biopsy. You will definitely go for the biopsy and you will get the result and you will see plasma cells there. So if 10% plasma cells are there, you will say, yeah, this is a single most accurate test. The best initial therapy, now for the treatment option, the best initial therapy is a combination of dexamethasone with lenalidomide or bortezomib or both. So we can go for the lenalidomide, we can go for the bortezomib or the both combination with dexa with steroids. And that is considered to be the best initial therapy. The best initial therapy for multiple myeloma, especially dexamethasone with lenalidomide or bortezomib, or you can use both. Myeloma therapy, this is point to ponder. Whatever is inside the box is point to ponder. We just need to memorize it. Myeloma therapy is in a state of rapid flux due to numerous advances. So myeloma therapy definitely is in a state of rapid flux due to numerous advances here. Melphalan is useful in older fragile patients who cannot tolerate adverse effects. So we can always go for this Melphalan choice, but only for the older and fragile patients who cannot tolerate adverse effects. The most effective therapy in those under age 70 is an autologous bone marrow transplant with stem cell support. So we can go for the most effective therapy in those under age 70 is an autologous bone marrow transplantation. So we can go for the autologous bone marrow transplantation if age of the patient is below 70 years. This is used after induction chemotherapy with lenalidomide and steroids. We'll go for the lenalidomide and steroid for the first option. Then we have daratumumab, which is an anti-CD38 drug used in relapse. So in relapse cases, we can go for this daratumumab, right? And for those who are having under age 70, we'll go for directly for the bone marrow transplantation with stem cell support, or we can go for induction chemotherapy with lenalidomide and steroids also. Now, bortezomib use has a high risk of inducing neurological complications. So, if you are asking for the bortezomib, so that is actually associated with neurological complication. Thalidomide and lenalidomide have a high risk of increasing clotting. So, clotting can be increased with the help of this thalidomide and lenalidomide. So, be careful and give prophylaxis against clotting when using thalidomide or lenalidomide. So, if you're really using thalidomide or lenalidomide, so you must give prophylaxis against clotting. So you can't leave it like that. You have to give prophylaxis against clotting whenever you are using thalidomide or lenalidomide. So now we are coming towards monoclonal gammopathy of unknown significance. So IgG or IgA spikes on SPAP are common in older patients. The main issue is to evaluate with bone marrow biopsy to exclude myeloma. So specifically SPAP is for the older patient, those are having IgG or IgA spike and they are old. We will go for this we'll go for especially SPAP, but in case of old patient, and the main issue is to evaluate with bone marrow biopsy to exclude myeloma. We have to exclude myeloma. Monoclonal gammopathy of unknown significance has small number of plasma cells. So we are going to see small number of plasma cells with this particular thing that is known as MGUS, that is monoclonal gammopathy of unknown significance. So there is no therapy for this MGUS, although about 1% a year transform into myeloma. So we should take care of it. Why? Because there is less chance, but 1% are still there every year. They can transform into myeloma. Especially the quantity or amount of immunoglobulin in the spike is the main correlate of risk for myeloma. More MGUS, more myeloma. So if it's more monoclonal gammopathy of unknown significance, we are going to see more myeloma in a patient. Now we're coming towards smoldering myeloma. Smoldering myeloma is characterized by 10 to 60% plasma cells with an M spike on SPAP. So you're going to see 60% plasma cells. They are not here 10%. They are here starting from 10 to 60% plasma cells, and here we are going to see M spike on SPAP. There is elevated urine monoclonal protein and elevated FLC ratio, but no hypercalcemia. You are not going to see hypercalcemia here. You are not going to see renal failure here, anemia here, or bone lesions here, and there is no specific therapy also. Serum free light chains, that is FLC ratio of 100:1 is highly consistent with myeloma. So this is very important point. If you're going for the serum free light chains ratio of 100:1 is highly constant with myeloma. So this is the special point for multiple myeloma. Now we're coming towards Waldenstrom macroglobulinemia. So this is the overproduction of IgM from malignant B cells leading to hyperviscosity. So here you are going to see overproduction of IgM from malignant B cells. Actually malignant B cells, they are overproducing and they are overproducing this IgM, and that will lead to hyperviscosity, and it presents with, there will be lethargy, there will be blurry vision, vertigo, there will be engorged blood vessels in the eye. There will be mucosal bleeding, there will be Raynaud phenomena. So these are all the things which your patient might present with, right? If it's a case of Waldenstrom macroglobulinemia, the patient must be very lethargic, fatigue, he's having blurring of vision, and he's facing vertigo. There are engorged blood vessels in the eye, mucosal bleeding might be there, and Raynaud phenomena can also be there. Raynaud phenomena, especially these peripheral extremities, they are bluish. And when you keep warm your patient's body temperature, definitely they are going to start, cyanosis going to get better into, definitely cyanosis will become better and it's converted into pink area. More blood supply will be resumed there. Now anemia is common, but an IgM spike on SPAP results in hyperviscosity. So anemia we're going to see, but an IgM spike on SPAP, that's the most important thing. We usually find this in case of hyperviscosity, and there are no bone lesions. You're not going to see any bone lesion here. Plasmapheresis is the best initial therapy . Sorry for the interruption. Yeah. Okay. So, yeah. What was that? Where were we? I think we're here, right? Yeah, so these all are the features of this Waldenstrom macroglobulinemia. So this Waldenstrom macroglobulinemia, this is the overproduction. We are going to see overproduction of IgM and from malignant B cells. So definitely they are not normal cells, they are malignant cells, and leading to hyperviscosity. So hyperviscosity, the thickness of the volume of the plasma definitely will be high because these are the malignant cells and they are producing more and more and more IgM, and your patient might presenting with lethargy, there will be blurring vision, vertigo, there will be engorged blood vessels in the eye, there will be mucosal bleeding, there will be Raynaud phenomena. So these all things we are going to see in our patient. Now anemia is also common here, but an IgM spike on SPAP results in hyperviscosity. So this is very important thing. We are going to see anemia, but why we are seeing hyperviscosity? Because there are more and more IgM spike on SPAP, and IgM are definitely high here. Why? Because of malignant B cells, and there are no bone lesions. We are not going to see any punch or lytic lesions here. Plasmapheresis is the best initial therapy. So that is the most important point for this Waldenstrom macroglobulinemia, that here we are going to see what plasmapheresis, which is considered to be a best initial therapy to remove the IgM and decrease viscosity. So in order to remove the IgM, which is actually producing from the malignant B cells, and because of that there will be much more viscosity. So we want to decrease the viscosity and we want to remove the IgM cells. That's why we are opting for plasmapheresis. Long-term treatment is with rituximab. So if you want long-term treatment, we'll go for the DMARD, that is rituximab. We'll offer steroid like prednisone and cyclophosphamide. Control the cells that make the abnormal immunoglobulins. Definitely these malignant cells, we need to take a control of it. Decrease the means of production. Use bortezomib or this lenalidomide as in myeloma. So in myeloma patient we are using this bortezomib or lenalidomide. So both these medications we are going to use here in Waldenstrom macroglobulinemia as well. So important point is plasmapheresis, which is best initial therapy, the presentation, and this IgM spike on SPAP, which is actually responsible for hyperviscosity. That is the most important point here. Now we're coming towards bleeding disorders. The first step in the evaluation of bleeding is determining if the bleeding seems related to platelets or clotting factor. So bleeding is actually because of the platelet, or it's a platelet type of bleeding with the normal platelet count, and that is because of clotting factor. Bleeding in the brain or the GI can be from either platelet or clotting factor deficiency. That's point to ponder. If it's in the brain, we can say in the brain or in the GI, it may be because of the platelet count deficiency, or maybe because of the clotting factor deficiency. So now we're coming towards types of bleeding. So platelet bleeding, if it's a platelet bleed, or if it's a factor bleed. If it's a platelet bleed, that must be a superficial bleeding, and if it's a factor bleeding, it must be a deep bleeding. In case of platelet bleeding, we are going to see epistaxis. Definitely it's a superficial blood, right? So maybe nosebleed, epistaxis, gingival bleeding, petechial rashes, purpura, mucosal surfaces such as the gums, vaginal bleeding, these are all superficial. These are all platelet bleeding. But in case of factor bleeding, if it's deep, then definitely it's going to involve joints and muscles. Now, first we are coming towards ITP, that is immune thrombocytopenic purpura. What is the most likely diagnosis? How you are going to diagnose your patient? You have to look for isolated thrombocytopenia. You have to see if it's isolated or not. How you are going to see if it's isolated? You are going to see normal hematocrit with normal WBC count. If the hematocrit is normal, if the WBC count is normal, so definitely only platelets are coming down. So this is known as isolated thrombocytopenia. Only you are going to see low platelet count, and here you are going to see normal size spleen. There will be normal sized spleen in this case. A 23-year-old woman comes to the emergency department with markedly increased menstrual bleeding, gum bleeding when she brushes her teeth, and fatigue on physical examination. Physical examination is otherwise normal. The platelet count is 17,000. She is having increased menstrual flow, gum bleeding is there while she is brushing, and fatigue on physical examination. 17,000 platelet count. What is the most appropriate next step in the therapy? So if it's 17,000 platelet count, which is below 20,000, it means that we are going to give here steroids, and that is prednisone. That is considered to be the most appropriate next step in therapy. Why? Because the bleeding in this case is mild, meaning there is no intracranial bleeding or there is no major GI bleeding, and the platelet is not profoundly low. They are low like 17,000. But prednisone is the best initial therapy. So we can go for the prednisone here, which is the best initial therapy, and initiating prednisone is more important than checking for increased megakaryocyte or the presence of antiplatelet antibodies. Despite of doing these antiplatelet antibodies, that is number D option, and this increased megakaryocytes, so we are not going to go for the checking of all these things, which is characteristic of ITP. But bone marrow is really needed. Bone marrow is really needed. We will never go for the bone marrow biopsy. It's really needed. But here they are asking for the most appropriate next step. They are not asking us the most accurate step, just the next step. So the next step will be starting of steroids. Why? Because it's more important than checking. We are not going for the check of this megakaryocyte or presence of antiplatelet antibodies. We can do it later, but right now the next step will be prednisone. That is most important here, and here the bleeding is mild. Now for the diagnostic test, ITP is a diagnosis of exclusion. Occasional diagnostic tests are antiplatelet antibodies, lack specificity, limited benefit. So for ITP, we usually go for the diagnosis of exclusion, and occasional diagnostic tests will go for the antiplatelet antibodies, which actually lack specificity or limited benefit is there, but we will go for it. Ultrasound or CT scan, we can do this ultrasound, we can do this CT scan, just in order to exclude hypersplenism. So we are just going to exclude everything one by one, and at last we will see this is a case of ITP. Megakaryocytes are elevated in number, here we are going to see, and bone marrow not routinely indicated, only before splenectomy. So we will never go for the bone marrow biopsy testing. That's indicated only when we are opting for the splenectomy. So before splenectomy we can go for the bone marrow biopsy. Other than that, it's not routinely indicated. Increase in mean platelet volume. So this is also one of the diagnostic tests. We are going to see this increase in mean platelet volume. Now coming towards the treatment option. So what are the presentations and how we are going to manage our patient? If there is no bleeding in our patient and the patient is having platelet count which is more than 30,000, this is very important. This block is very important. If there is no bleeding and platelet count is more than 30,000, we are not going to give anything. If there is mild bleeding and the platelet count is less than 30,000, like in our case above, we'll go for the glucocorticoids. If there is severe bleeding like GI or intracranial bleed and the count is very low, like below 10,000, we'll go for the immunoglobulin, we'll go for the anti-Rho, and that is anti-D. We are going to give anti-D. So anti-D and immunoglobulin, be noted that we are going to give this immunoglobulin, especially if the platelet count is less than 10,000. Normal platelet count is 1,50,000 to 3 lakh, right? So if it's less than 10,000, if it's associated with severe bleeding like GI or CNS bleed, then only we'll go for this immunoglobulins or anti-D injection. If there's recurrent episodes and steroid dependent, we'll go for the splenectomy. If there's recurrent episodes, we can go for splenectomy. Splenectomy or steroids, not effective. We are already done with the splenectomy and steroids are not effective. Then we will proceed to this romiplastim or L-Trombopac or rituximab or azathioprine, cyclosporine and mycophenolate for the chemotherapeutic option. So we'll go for these treatment, but after splenectomy and once steroids are not effective. So we have to make a note of it that platelets are large in ITP because they are megakaryocytes. Megakaryocytes, actually the fragments of megakaryocytes is platelet. Megakaryocytes, a big cell. Once it starts fragmenting, it's producing platelets. So you're not going to see here platelets, you're going to see here megakaryocytes. So that's why we can say these platelets are large in ITP, that is megakaryocyte. So again, this block is very important. This point to ponder. Before splenectomy, give vaccination to, we'll go for the vaccination of Neisseria meningitidis or Haemophilus. Before splenectomy, give vaccination to Neisseria meningitidis, Haemophilus influenzae and pneumococcus. So we can give all these vaccinations prior to splenectomy. And romiplastim and L-Thrombopag are synthetic thrombopoietin for ITP. So if we are going for the ITP, especially treatment, we'll go for this romiplastim and L-Thrombopag, which are actually synthetic thrombopoietin, and that's a synthetic one, especially for ITP. And this block is very important. We give which vaccination before splenectomy? Before the Neisseria, for Haemophilus, and for pneumococcus if we are actually going for splenectomy. We'll give prior to it. Alright, so I'm just going to stop it here. So inshallah we'll continue tomorrow. Thank you so much.